Thank you. I'd also like to acknowledge
Microphone.
right there, okay. Also like to acknowledge traditional owners of the land, and also I want to thank Mel, Renee and Jenny for talks that's going far better than mine.
Microphone.
Microphone. All right, I'll let it rest on their beard, so I'll be in touch for the entire time. I was really grateful that Kevin, the Minister, Kevin Humphries, was able to give a talk, and he talked about some of the successes that we're having. And he made a little allusion to something that's going on here, Project Air and Rock, and he talked about making it available to roll out. I'm going to talk a bit more about that. But I just want to actually just say a little bit about things from a bureaucratic point of view. I know you don't want to hear bureaucracy, but in fact, bureaucracy is what makes all the wheels go round. And one of the reasons why I've devoted myself to that kind of stuff, which is around development and happening.
Can't hear you.
Well, I could swallow it. Anyway, I won't say that I was reminded of the thing on the Masters and Johnson last night. I could swallow it if that was the case. In this state, I'm going to mention you later, Angela. In this state, we run a lot of services, but one of the things that we actually realise is the need to diversify, change and actually improve. And I guess one of the great criticisms of mental health services has been that we haven't actually improved very much over a long period of time. And I'm just going to say that, is it possible to improve by the use of documents? There are two things that I've got here that I just want to use as background for what I'm going to talk about. One is the National Framework for Recovery-Oriented Mental Health Services. That's policy in theory. There's also a practice guide as well. And that's just recently been released. There's been a movement in this country which has been put forward by people who have been living with mental illness, again, about getting the system to change to acknowledge the notion of recovery. And I guess that one of the things that has really been driven by has been people who've lived with long-term psychotic disorders or affective disorders. And in one way, this conference has been a little bit for people who've been feeling that for borderline personality disorder, they've been left out of the mainstream story. And I think that's a really unfortunate thing that needs to change. I'm going to talk a little about some of that mainstreaming stuff. Secondly, although that's actually a blow-up, that's actually the clinical practice guidelines for the management of borderline personality disorder in Australia. And we've got two of the authors going to speak next to us, so I don't think I'm going to say too much about it, except that we've got a really good collection of the evidence base about what to do. And in fact, there's only 4 such NHMRC clinical guidelines for the treatment of particular things in the mental illness field, and this is one of them. So it's actually a high-level piece of intellectual property that is going to guide the way that we should do things. So there's a combination of the two things, the recovery and the guidelines that are going to work. Now, obviously, that's policy, and how are you going to translate that, and what are you going to do about it? So let me set a bit of scene for us. I mean, Kevin Humphries said that personality disorder affects 5 to 13% of people, and 40 to 50% of those are the people who are diagnosed with mental health conditions. A lot of people. Now, in New South Wales, we would think around 4% of people, maybe you could argue more, it's an American study that says 6% of people are diagnosed with borderline personality disorder, or are diagnosable, I should say, rather than diagnosed. If you think about that, our population is 200,000 people. In terms of our admissions to hospital, around 4% of people admitted to hospital, mental health hospitals in New South Wales have a primary diagnosis of borderline personality disorder. And in some places that's up to 11%. Now that doesn't count the people who have a secondary diagnosis, and doesn't count those people whose diagnosis is clouded by self-harm attempt or a drug and alcohol problem or some other thing. So it's actually quite a significant problem. I was actually talking to the ED people yesterday, the emergency department people. We don't have a way of pulling that particular figure out of our emergency department presentations, but we know that it's an enormous number. And I think that the Ministry is also talking about the fact that this enormous number has led us to a lot of stress and strain and to a lot of problems to people in terms of re-traumatising or ignoring or not getting the right kinds of care, so we want to do something about that. Now, in a way, it's been, as I'm sure you have got this day together, because it's been an unsung thing. And I think about my days in mental health, and I'll come back to a couple of them in a minute, when we first started getting together people, families, consumers and clinicians to start to talk about mental illness. I started doing that 25 years ago, and I suppose that this is only the 3rd one of these. I think that we're a long way behind in that kind of get-together stuff. I was really amazed to hear Jenny say that to get together a group of carers to talk about their stuff has not happened for her, and she's been around for a long time, whereas I think that a lot of my research effort has been around the treatment of schizophrenia, and we've actually had family groups, and we've had those kind of education, we've had that kind of support program for over 20 years. And, you know, if we've got an illness that's a bit more prevalent than that, how come we haven't had that kind of stuff all this length of time? So, let me say this, let's talk about some of the good news, and I want to sort of come back to this. When I first started my journey in psychiatry, and I'm sure you'll remember this, I draw the parallels to schizophrenia. When I first was a young psychiatrist, I had my first psychotherapy case. I saw a young man with borderline personality disorder, and I was given a theory about how it was probably likely good and bad, and his mother had something to do with it, and it was all kind of perpetuated in the family. And I read my stuff, I read my masters, and I did the therapy, and he was actually quite a nice young man in the end, and we all did quite well. And then later I did some stuff with Russell Mears, and we actually started on self-psychology, and did training in that, and we actually, by treating people normally, and actually with decency and listening and actually understanding and tracking the emotion with those people, we're actually able to make a change by virtue of modelling what the change should be. And now, of course, we have much better treatments as well. We have DBT and so on. Others are going to talk about those much better treatments. But I think that the first thing that's really a good piece of news is that it's no longer about mothers and about families and that kind of stuff. That the stuff that I think was in that first video, which is around the notion of a biological predisposition to an emotional insensitivity, the notion of a pervasive, emotional dysregulation, I think is really something. So I'm going to now try to actually take that HSS thing and stick it in my speech. All right? I might learn something about whether we can actually change the name. That's going to take 20 years, but it might be a good thing to do. So that's the kind of stuff that bureaucrats can do over a 20-year period through a series of papers. We can get those things changed, and I'll take that on as an occupation. I'll probably lapse back into the other stuff, because you can't actually speak in TLAs, three-letter acronyms, all the time, absolutely accurately. I was in another state during this week trying to help them do some stuff about their service, and I said, just excuse me if I lapse back into New South Wales speak and not speak your speak, because we can't speak to speak. I guess that's one of the problems, isn't it? That how are you going to get people to speak that everyone can actually understand? And I think that's what our next two speakers are going to talk about as well. So that's one piece of good news. The second piece of good news is this notion about failure to diagnose. Right? There's been an acknowledgement that people who potentially are diagnosable with borderline personality disorder, whether diagnosis is a good thing or a bad thing, that's up to you to decide, that many people don't get diagnosed or don't get recognised. And one of that's been because some of the other problems have hidden what's been going on for them, like the drug abuse or the kind of crisis staff has hidden that stuff, and people get angry or it's stigma. Or it's also about a kind of positive stigma thing where the clinicians don't want to put that diagnosis down on a piece of paper because they think that's going to be bad for the person in their journey through the system. If they understand, they won't do it. And I suppose that for me, we've got to actually have that kind of language because, again, bureaucracy wants to have numbers, it wants to have language, it wants to have acknowledgement. And once you get acknowledgement of a problem, you get an opportunity to change it. If you don't get acknowledgement, you don't get any opportunity to change. So I think that one of the things that this day can do is that the general movement of acknowledgement makes a difference to the notion of how to diagnose and how to count the figures, and that will make a difference. So that's a piece of good news, unfortunately. Thirdly, we have therapies that work, and I was really pleased to hear people talk about, and I'll let other people talk about that. And again, I've made the point about the other piece of good news is about the rise of families, right? After I did the after I did the self-psychology training, I actually found it all a bit hard and overwhelming, as people do. I went to work in schizophrenia, where I did a lot of work with families about insight and acknowledgement and people's understanding of what was going on. So I'm really, again, pleased to see that following that parallel track, perhaps 15 years later, of what we're doing, in that area, we can have that kind of family involvement. That means that we've stepped out of being the blame ones to the ones that actually are being understood and helped and cared for, and it's a partnership. It's that unholy triangle that I often show to people, but I'm not showing too many slides because I have what I call a 5-slide rule, which is that if you take more than 5 slides to explain what you're talking about, you don't know what you're talking about. So we can have the next slide, if you like. Thank you. of my 3 slides. Okay, this is from the recovery framework. It defines personal recovery as being able to create a life and live a meaningful and contributing life in a community of choice with or without the presence of mental health issues. But that encapsulates some of the things I was talking about before. That mental health issues doesn't mean about diagnosis, is borderline personality or HSS, a mental illness or not. It's about whether or not it has some effect on you. And the other is that when I've looked at all the recovery sites that are for what I'm going to call HHS, which we'll call BPD, recovery sites, the notion of living a meaningful and contributing life in a community of your choice is exactly what people are talking about. Now, this is from the mainstream recovery document. This is from the document that starts to acknowledge the trauma that we've caused through mental health treatments. This is the document that's around how staff and how services are going to reorient themselves to what you do. I say that in this is the next great piece of good news. That clinicians are quite good at actually getting a new message. Individually, they'll get the message, they'll understand it. When they work in teams and when they work in services, they can actually reorient and get that message too. But when you actually start to take the whole thing, the whole system, the whole service, it's a huge ship. And turning that ship around is very, very hard. So we have the first 2 steps to turn around, but we need a whole thing. Now this is why I want to come to just a little thing that I think is important in this stuff, and a criticism, I think, of what we've been doing in the past. One of the things that we've had to do to get HHS recognised is to make it very special. It's really important. It's a terrible thing. And it is true, that is very true, very, very, very special. But that we have to have very special treatment because we only, people who really understand and really empathise can treat that. And in a way that's kind of excluding to the kind of mainstream treatment too, because they don't do it very well. But one of the things you have to acknowledge is that to get it right, everybody in the system is actually going to have to be able to do something properly. Everybody's going to have to be at least able to acknowledge that this is a problem, be able to offer some first aid type advice, and then be able to turn the ship around by offering an entry into the right kind of service, the right kind of treatment that people need to have. And so what I think is going to be the next big challenge and the next piece of good news, and I'm going to talk about that just slightly as to what we've done, is to get that mainstream thing happening. Now, the other thing is that it's not going to be the whole role of government services. You know, I'm very happy to hear you talk about the psychological rebate stuff, because that's the Commonwealth, not the state, so I don't have to worry about that. But the reality is that we all have to get that kind of bureaucracy joined up to make a difference around that. So, could you just have the next slide, please, the last slide that I have? I don't know if people have seen that. That's a recovery model from a guy called Mike Strait and others. And it talks about 5 things in personal recovery. Recovery is not clinical recovery. It's not an absence of symptoms. It's not about some kind of cure. It's about that thing about getting your life right, about having meaning and purpose in your life, about what people have talked about already, the hope and optimism, the connectedness. And particularly, I think, for HHS is actually Health Hospital Service in Queensland, so that's why it's really hard in mixed medical. That this issue of identity, who am I, and the stuff about emptiness. Now, identity works both ways. It works in services as well as it works for individuals. And when Janelle talked about that thing of emptiness, I often think about when clinicians are confronted with, I just feel empty when this person is here, I don't know what to do, I don't have that piece of skill inside me to actually make a difference to that. So the issue is around how to empower both sides of the equation to do that, how to stand by what's called a supportive autonomy to actually get people, services to actually help people to get that autonomy that you need to have. So those are the things that I think are the good bits of news. Now here's my little story. When I first came to New South Wales in 2009, this is a good story, that I took over a group that was the Clinical Advisory Council. All the senior clinicians in the state were responsible for delivering services. I said, what are we going to do to make a difference? What's the thing that makes your life the hardest in terms of running a service and doing stuff? And one of them, who's sitting over there looking at his computer, apparently just told me in the break, I didn't remember that he said this, but he reminded me, because he always reminds me, he said everything first. Angela Vergona said that I actually think that this, what we then call borderline personality disorder, is something that we have real trouble with dealing with, and we're trying to work our way through what to do. And in fact, there was a general consensus that this was actually the biggest issue that was facing us in terms of what we needed to do to improve. So what we did was we thought about what would be the shape of a service, what would be the shape of the things that we would want to have that would at least make a difference or make it not so terrible. And the first one was that we would legitimise the right for people with what we now know as HSS to be in treatment and be recognised by the medical and mental health services. That there was too much of this, you've got something that isn't even in our bailiwick. So we made a statement that this was going to be in and not out. Right, first one. The second thing was we thought, well, that's very good, but we actually don't know what to do now that we've got it in. So we thought, let's get some science on it now. And we devised the notion that the things that we wanted to happen would be that we would have to have people who had knowledge about what was needed to be done. We'd have to have, once they had that knowledge, something for them to actually do, or some kind of service, some kind of thing to happen that would work for people. And that what I knew about systems was that unless you had leadership and leadership commitment and challenge and change, then it would never be so. It would just be policy, right? So we came up with the idea that we needed to develop that. And we thought, we don't actually know how to do that yet, but we're sure there are people around, there are a lot of very good people, a lot of good pockets of work in New South Wales. So we put out a tender. So we'll give you $1 million a year if you can work this thing out, if you can work out how it's going to be done. We actually got 4 very high quality tenders. It's quite difficult to actually determine which one of those was going to get the tender. But it turned out that Project Air, which again the Minister mentioned, was funded to work, and Bryn's going to tell you more about that, so I won't go on about that, but funded to work in South East Sydney, Illawarra and Justice Health. And the whole thing, the whole important point about it was there was a combination between a university, so there was actually some credibility in terms of the evidence, and a health service that was willing to change, or health services that were willing to change. Now, Project Air addresses this gap with 6 key strategies. One, as I mentioned, redesigning services. 2 is upgrading the staff of mental health people. 3 is evaluating the outcomes, because data drives change. Connecting with families, carers and consumers. Improving awareness and information. And enhancing the quality of clinical service. Another one that I'll just add that they've actually done, which I don't think I talk about, is actually trying to get back into our child and adolescent services and change the attitudes and trajectories that people have. Because one of the issues we found was that diagnosis and recognition often takes a long time to struggle and tragedy before we get that. So we need to change that, get that earlier intervention thing. So the evaluation of Project Care has demonstrated significant improvement in staff confidence and skills, a 73% reduction in hospital admissions for people. Sorry, Brendan, this is what you're going to say, but I just want to re-emphasise this message. A 50% reduction in the number of days that people spend in hospital, and a 73% reduction in emergency department visits. Now, if that's not improving functionality on both sides of the equation, for me, it's got to look at how we're going to supply the service and the money, and for the person who's actually got to get the service and feels confident about what they're actually going to get, and that means that they get a diversion into some meaningful form of care, then that's one thing that we're going to do. Now, what I had hoped to say was to give a bit more details about how we're going to roll that strategy out around the state. We're still working on that. That's, I hope, maybe for the next one, we can talk about those kind of successes. But I think that the great opportunity for us is the combination of recognition of recovery and the recognition that we have something that we can actually do something about. So, no longer will I have to face that emptiness that people come in and say, yeah, but I just didn't know what to do. And that's a service person saying, I just didn't know what to do, so we did this. And when they ring me up in the middle of the night and say, well, did you talk to the family? Oh, no, who are they? That, in fact, we have everybody with the knowledge of doing that. That every clinician that you meet will actually know what it is. And if they can't perform the treatments themselves, they'll know how or what you should get. They'll know how it should be done, or sent away to be done, to at least have some continuity and change. So that's my hope and vision for this HSS thing. And I hope that we're going to hear it's actually going to be done by the other 2. So thank you very much.